Well, good afternoon, ladies and gentlemen, from a magnificent Cape Town. There's not a cloud in the sky, the sun is shining, and from where I'm sitting, I can see an aeroplane landing at the DF Milan airport, and also the beautiful mountain ranges in the background. With There's snow on the top of the peaks, the highest peaks. That's why it's so cold here, Steve.
I don't
With
see any
me,
snow
you
peaks.
don't.
Are you serious?
No, they were on the highest peaks, Steve. With me here is Professor Steve Jeffrey. He's our co-producer this evening, and we look greatly forward to having Professor Steve Eppel speak on managing chronic pelvic pain. Now, he's new to the platform of the Pelvic Floor Foundation, and he's got a Steve Apple computer, so we're just having to download the Zoom presentation and reload the Zoom application. So while he's doing that, he is with us. He's just redoing that. We have the very, very capable assistance of our trusty technician, whose name is Chris. Those of you that manage gynecological patients would know the enormous clinical challenge presented by chronic pelvic pain. Um, Many years ago, there were one or two options. It was either pelvic inflammatory disease or endometriosis. But now we know, with a greater and deeper and more profound understanding of the physiology involved, it's often much, much deeper than that. And that's why we thought this evening, Steve, we'd get a urologist, Professor Steve Eppel, to come and give us his insights into the causes and management of this. As you well know, the pelvic floor is almost like a parachute inverted, and there are many organs, including the bladder, the uterus, many nerve endings, and of course the rectum. So very seldom do you get only one form of dysfunction. It's often a smorgasbord of dysfunction that causes pelvic pain. And for this reason, we're looking forward to the insights that Steve Apple's going to produce this afternoon. Chris, have you downloaded and reset and reformatted the computer of our guest?
We in the progress, in the
Yeah, I
process.
think you're in the process of doing that.
Well, while they're in the process, Steve Apple is from. He spent some time in America, and he's picked up all sorts of wonderful insights over there. He's a urologist that works at the Chris Barnard Memorial Hospital over here, and he certainly helps us out from time to time with difficult and tricky um, and thorny pelvic floor problems and, of course, urological issues. Steve, do you know,
Yeah,
you familiar with
I know,
Professor Steve Apple?
I know Steve well. I do remember calling him about 15 years ago when I was doing a locum, and the patient presented with some problems with urinary retention after C-section, but in fact, it ended up being an injury to bladder.
Injury to the bladder, huh?
Yeah. But that was my interaction with Steve initially. But since then, Steve has been a great help. He's got a very deep interest in arguably one of the most difficult problems we see in gynecology, and that is chronic pelvic pain, which is difficult. We see them all the time, but these aren't often straightforward problems to fix. And
Yeah.
Pete, and you've obviously got years and years of experience with these patients as well.
Yeah, in the olden days, Steve,
Yeah.
we just go and do a laparoscopy and sniff around and see what we can find. But of course, that isn't the answer, because you've got to have a better appreciation and understanding of the pathophysiology of what causes it, the neurological innovation,
Yeah.
and how we're going to manage it.
Pete, what do you think of the placebo effect of a diagnostic laparoscopy? Do you think it's a real thing, or do you think it's something that is very short lasting, or do you think we um, are sometimes inappropriate in doing a laparoscopy on these patients? Don't you think sometimes that the very fact that you tell the patient it's normal, that they're very happy? And I see Steve's hand is up already, so maybe that's a good
Well, I'll
time
just answer your
to bring him
question.
on.
Steve, that's a very good question, and thank you for raising it. It's just that nowadays, Steve, I was alluding to what happened in the past. But remember, in those past days, we didn't have MRIs. And I can tell you this, that as expensive an MRI is, it's still a quarter of the price of a laparoscopy in a day in hospital.
And it is very helpful.
And it is very, very helpful.
Yeah,
So
absolutely.
this hinges on what I said, is that it's not just either PID or endometriosis, and let's go and see which one it is by doing laparoscopy. There's better imaging, there's better understanding, and I'm sure now that Steve's got his slideshow, we're going to be hearing which these options are. Steve, good afternoon. Can you hear us? Steve Apple, that is.
I can hear you. Can you hear me?
We can hear you. And are your slides functional now, Steve?
Well, the slides are ready. I don't know whether you can see me. I've got video here switched off for some reason. I don't know why I can't get that
Yeah, we
to.
can see you now. Yeah.
Can you see
Hi.
me? Fantastic.
Yeah.
Okay.
But
So
we
now
can't
the
see
next thing to do, thank you for
Slides, Steve.
yeah. So let's
You and
see
your
if we can. Do you see the slides?
No, we can see the roof of your holiday house in Aspen, Colorado, but we
That's right.
cannot see the slides.
Okay, good. Okay, it's a start. I'll come back to Scarborough. All right, raise hand, share. Share. Okay, here we try this again with the sharing. Allow. Zoom us. Okay, allow.
Chris, are we on the right track?
I believe so. I believe so.
Desktop. Yes, 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 yes. Okay, do you see the disorganized laptop now? The laptop.
Yeah,
You
we
see
can.
it?
We
All right,
can.
great.
Perfectly.
All right. Now do you
There
see
we
the
go.
We
presentation?
can see the slides. Yeah.
Well,
We
what
see
do
the
you know?
Vitruvian Man.
The what?
The Vitruvian Man.
Exactly.
We're talking about pelvic pain in women, Chris.
Oh, you didn't tell me that.
Thanks, Steve.
Well,
We've
thank you,
really done
Peter.
your welcome and your introduction. So, without further my wasting time,
Yeah, indeed.
thank you very much indeed for being with us this afternoon.
Thank you, Peter and
Even
Steve. I also want to thank two people who I think are online with us. The one is well known to you all is Karina Avni, with whom I've collaborated for many years, a pelvic function and pain expert, physiotherapist. And the other person is Helen Room, also a pain expert, OT, who's helped me with our educational support group, which we run. So, chronic pelvic pain has mystified and intimidated the medical community for many years. I'm sure you'll agree. And that's probably because of the multiple sites within the pelvic organs, the way it can present, the dysfunction within the viscera and the musculoskeletal structures. What's going on? It's been confusing. It's also been difficult to manage. But interestingly and fortunately, there's been a great deal of research and understanding. And if you read the EAU, the European Guidelines on Chronic Pelvic Pain, it's 3 pages of very dense information, well researched, very interesting reading for those of us who have the time and are interested. But it doesn't really provide a practical approach, at least not to me. And so what I've done over the years is distilled the cleverness, the research from these clever doctors into a pathogenesis that I can understand, and an approach to management which makes sense to me and seems to make sense to our patients. And it's that presentation that I would like to give to you all this afternoon. Let me know if you're not seeing or hearing anything and interrupt me. You can still hear me? All good, folks?
Indeed, yeah. All good, all good.
Okay. Good, good, good. Okay. So we're going to talk about the classification and the prevalence, such as we know it. I'm going to give you some case studies so you know examples of how or what we're dealing with, the neurobiological pathways, the pathophysiology, the neurology. How is pain chronified? How does pain become chronic? And then what is chronic pelvic pain? The variable presentations, why it is unique, its pathogenesis, and its management. A couple of key questions. What is pain? We're going to talk about in a minute. How does it become chronic? And that's for a little bit later down in the show. And how is chronic pelvic pain unique? Okay, those are some of the key questions that are going to come up. What is pain? Is it a signal that you receive in the brain? The sense, the nociception travels up the nerves, and you sense it in the brain, much like you sense auditory input or visual input, or is it something else? Well, the neuroscientists believe, and do I need to move this other way so you can see? Or you can see the main, I guess you can see this. But let me just move
Yeah.
the little guy out the way. Okay.
Okay.
So pain is an affect, like feeling hungry, feeling too hot, too cold, fear, lust. It's like an emotion, described as such by this gentleman in 1998. It's highly subjective, with each person's unique experience determined by genetic and epigenetic factors, as well as other factors such as memory and present context. That's pain, okay? There are basically three types. There's nociceptive, which is the pain we understand very well. It's well localized. It's a response to a physical injury. The nerves, when it is healed, when you're treated with whatever you're treated with, it gets better and it goes away. That's nociceptive pain. Then there's neuropathic pain, where there's actual damage to the nerve, such as peripheral vascular disease, diabetes, multiple sclerosis, spinal cord injury, nerve damage, neuropathic pain. And then there's nociplastic pain, pain where there's no visible pathology to the nervous system, ostensibly. And interestingly, all of these kinds of pain can coexist or transfer from one to the other depending on the circumstances. What is chronic pelvic pain? There are all these names. As we alluded to, the pain can present and the dysfunction in different parts of the pelvic organs, and they've been given different labels: vulvodynia, coccydynia, proctalgia, pelvic congestion syndrome, prostate pain, prostadynia, interstitial cystitis. And you folks are the experts in endometriosis. Do they all relate? Are they separate diseases? Can they relate? Do they relate some of the time? And we're going to answer some of those questions. Now, with regard to the incidence, because the classification has been difficult, what has been done in the past is they've classified the syndrome according to these two common phenotypes. In males, chronic prostatitis, chronic pelvic pain syndrome, although we now know there's very rarely a itis in this, it's simply pain. And then interstitial cystitis, bladder pain syndrome in women, although we know that sometimes there's no visible evidence of any cystitis. However, given those phenotypes in the past, the incidents are up to 15% in both men and women, and that makes sense. Certainly, I know Steve, you see a large number, and certainly the folks that that we see, there seems to be the prevalence seems to be significantly high. In South Africa, Peter Kammerman did an excellent study, he and his colleagues, in which they described that up to 18% of folks in this country experience chronic pain. They didn't address pelvic pain specifically. Now, the EAU and other societies have simplified the classification, which to me makes sense. And that is either primary pelvic pain or secondary. The secondary pain is where there's visible pathology. So Hunner's type interstitial cystitis, where you see ulcers in the bladder, small capacity, obvious inflammation, and things like endometriosis. Those are real visible pathologies. Prostatitis, okay. But then there's primary pelvic pain, where there's no visible pathology. And that's the most common type, the most vexing, the most challenging, and what we're going to focus on today. Some examples: a 29-year-old female, lower abdominal pain, pelvic pain, with bladder and bowel dysfunction, often go together for many years. Often have a musculoskeletal component. The pain migrates from one area to the other. Started at the age of 14, and there was childhood trauma, probably sexual abuse. She had an early abortion later on, a lot of stress and anxiety. She's been to many doctors and many specialists, been thoroughly investigated, not coming up with very much. Questionable diagnosis of recurrent urinary tract infections, a common diagnosis thrown at them is the endometriosis. Laparoscopy negative, normal examination, good capacity bladder, clear urine. Here's a 39-year-old female, chronic pelvic pain for 8 years. Bladder pain with fullness, partial relief after voiding, incomplete. She feels like she doesn't empty properly. Bladder dysfunction, constipation, dyspareunia. She's stressed. They all have stress. She's had a gynecological evaluation, and they found minimal endometriosis at 2 laparoscopies, which didn't really help. Normal examination, normal urological evaluation. Here's a male, 28 years old, chronic dysuria, frequency, perineal and anal discomfort for 10 months when he saw me some time ago. Started after an unprotected sexual experience, kind of an extra relationship guilty thing that he did, and he had a little bit of a discharge, freaked out, and that's when his symptoms started. Persisted despite multiple antibiotics and visits to different doctors. He has a history, interestingly, of irritable bowel syndrome and reflux. We'll talk about a little bit, we allude to overlapping pain syndromes. Okay, in these patients with chronic pain, overlapping pain syndromes. The examination was normal. He did respond to Lyrica. He has a female, she's 25, she lives with her parents in Angola, severe pain for 4 years. Now, she had severe infiltrating endometriosis with a significant surgery, laparoscopic excision, bowel resection, initially successful. Pain improved, but wasn't really enough, and it got worse. So this is a situation where she had nociceptive pain, she had real pathology, got better, but it remained with her. She developed what we call a nociplastic process now. Okay. Interestingly, in her past, once again, severe menstrual pain starting at the age of 14, many visits to many doctors, not well managed. And we'll talk about the primed pelvis, which I believe is a big factor. And as a matter of fact, one author quotes 50% of women with chronic pelvic pain have a history of abuse in childhood. Here's the last patient to mention, a 23-year-old male presented early January 25, 4 years of deep pelvic prostate pain, exacerbated by ejaculation. It migrates, goes from one place to the other, changes in quality, a lot of stress around COVID, had a previous varicocelectomy. Normal examination, 2 MRIs, can find nothing. But he believes, and he believes to this day, that we're missing the diagnosis. He's focusing on the end organ, can't find anything, and he hasn't turned the corner. And I'll explain to you what I mean by turning the corner. We've known now how the pain pathways run for many years. You know, you have a nociceptive stimulus, travels up to small fiber sensory nerves, crosses the spinal cord at the level of dorsal horn, up the ascending pathways and to the brain. We've known about the descending pathways, how pain can be modulated, thanks to the gate control theory. Now, it was in 1965. Melzack and Walls described the gate control theory, in which they talk about a balance between the small sensory fibers in the dorsal horn of the spinal cord and the larger proprioceptive fibers communicating with each other, as well as the descending pathways providing facilitatory and descending signals to modulate pain. And that theory actually still holds water today. But what happens in the brain? Well, we now know and have a better understanding of the complexity of this whole process, where a distributed network between different regions of the brain, different hierarchies are involved in the sensory, the emotional, and the cognitive aspects of pain. So a hugely complex process involving different parts of the brain, such as the different parts of the cortex, the midbrain, the amygdala, and an area called the periaqueductal gray, a tiny area in the center of the midbrain, where it is proposed by neuropsychologist Prof. Mark Soames is the center of consciousness. So it's very fascinating stuff. The second mechanism of pain involvement involves this crosstalk between the CNS and the peripheral immune system. The brain, like other organ systems, tends towards homeostasis. So there's this homeostatic relationship between these two systems. And of course, the autonomic nervous system, the parasympathetic, sympathetic, And Karina is a particular expert in this aspect of chronic pain. But those are the three main regions and places where pain is expressed. These are the so-called neurological substrates for the experience of pain. But what is how do we actually experience pain consciously? What happens consciously? Well, it's quite interesting. The Reverend Thomas Bayes, who died in 1761, before he could present his theorem, I'm going to read it to you, an essay towards solving a problem in the doctrine of chances. Complicated stuff. Further described by the mathematics of this theorem was elucidated by Laplace, the famous mathematician. Now, the whole thing is fairly complicated, but I've tried to simplify it for myself because I can't get my head around the maths. And let me just read it to you. So the Bayesian approach to understanding brain mechanisms of pain frames the experience of pain as a process of probabilistic inference, where the brain combines prior expectations, beliefs, with incoming sensory evidence to generate the perception of pain. What this means in simple terms is there's a whole lot of things that have happened in the past, which are known as priors. Okay. You also have a genetic makeup preparing you for this experience. And the brain interfaces this past experience with incoming signals, sensory signals, to measure homeostasis. And if there's a mismatch known as error signaling, you experience pain. And the extent can be determined, the extent of the pain use and the quality is determined by the extent of this mismatch, the error signaling. And that's, I know it sounds a bit airy-fairy, but it's important when you think about how the psychological interventions work. Think of the placebo effect. You folks mentioned it in the introduction. This is thought to be how it all works. So those are brain mechanisms. Now, how does pain become chronic? How is it that when the initial stimulus is gone, we still experience pain? Okay, so this is just the summary. The brain doesn't passively receive pain. It actively it interprets the signals. It infers the most probable cause. These prior beliefs and sensory input estimates the likelihood of danger resulting in the experience of pain. Why does it? I have to click on the thing. So, Professor Clifford Wolff, who is one of the world's foremost pain researchers, was born in Johannesburg, and he actually presented to our academic conference at CBMH many years ago, was the person who presented this concept of central sensitization, which is the major mechanism in how pain remains, how it is chronified. He describes the central nervous system can change, distort, or amplify pain, increasing its degree, its duration, and spatial extent in a manner that no longer reflects the qualities of the peripheral noxious stimulus. And there's very sound experimental data to support this, such as amplification of the transmission processes in the spinal cord, the turning on of certain receptors, the enhanced synaptic transmission, and so on. So that's central sensitization. How I describe it, and patients like a name. You don't never say to a patient, "There's nothing wrong with you." I've looked in and out, I've done the MRI, and you never say to them, "There's nothing wrong." You've got central sensitization. It's like a Christmas tree that's glowing. It's not switched off. It's turned on. All right. Why does it do that? So central sensitization, and then there are two other mechanisms that maintain pain. This cross communication we mentioned between the central nervous system and the peripheral immune system can be disrupted, and that can result in pain chronification. Psychological stress. So these folks come to you, they're all stressed, just about, okay? And that exacerbates the process. It results in a cascade of neuroimmune and neuroendocrine responses, increasing error signaling we spoke about, and the midbrain, in the midbrain, and the prediction of pain. Pain is predicted by the brain, okay? So that's how pain becomes chronic. What about chronic pelvic pain? Is it unique? Well, yes, it's unique. You know, these sufferers don't talk to their partners, let alone their friends, about their pain in their pelvis. There's the psychological, the psychosexual aspect of this awkward thing that they're suffering from. So, and that aspect makes it special. And you know, when I talk to the folks, I elaborate on that. The fact that the pelvis should be a place of pleasure, if you think about it. A good evacuation, both ends, and good sex. And when you suffer with pain in that area, your whole psychological output changes. Okay, there's always a visceral and often a musculoskeletal component, the pelvic floor. You folks are pelvic floor experts. There's pelvic organ dysfunction. I alluded to the prime pelvis. In the history, you will almost always find something in the history, even if it's recurrent UTIs, that has primed the area for the development of the syndrome. By the time they come to us, they've seen several doctors, specialists, they've been investigated up and down. They've had an inadequate response to medication. They've had antibiotics, often have had surgical intervention. There's no visible pathology. They're desperate. They demand a diagnosis and a cure. A word about endometriosis. Again, you folks are the expert, but I think you'll acknowledge that the volume of endometriosis isn't proportional to the degree of pain. And in fact, that you can have endometriosis without pain, and you can have endometriosis with pain. It's like interstitial cystitis in a sense. So that's another story. So what do we do? By the time they come to us, you need to sit down for a good hour or more and listen. They're recognizable patterns. They tell the story. You'll soon see, if you get to know these patients, you'll know you won't have to examine. They've been examined by your colleagues very thoroughly. You recognize the overlapping pain syndromes, irritable bowel, fibromyalgia, chronic headaches. They're all stressed. You obviously need to exclude visible pathology, which may have been missed. A word about interstitial cystitis. This is bandied about. Everybody's got interstitial cystitis. Well, they don't. Very few people have demonstrable Hannes-type ulcers in their bladders, small, contracted, angry bladders. That's interstitial cystitis. The others, you can call them irritable bladders. You call them the bladder pain syndrome. But it's not interstitial cystitis. They've developed central sensitization. And it's important to avoid unnecessary investigations, because you don't need to do a cystoscopy on a 24-year-old who's got nothing there. You're only going to flare the situation. And it applies, quite frankly, to over-investigation, invasive investigation. By not recognizing the syndrome early is how it becomes chronic in many ways. So they sit down in front of us and we talk. We simplify the concepts. The pathogenesis may be fairly complex, but you can simplify it so that they understand it. They really understand the concept of central sensitization, not difficult concept. Need to modify their expectations. I say to them, don't expect a silver bullet. Your pain may never go away, but it definitely can get a lot better and you can live a wonderful life. There's no question about that. Our role as urologists and gynecologists is very important because we're the last stop. They come to us eventually. They've been everywhere else. when you encounter these folks at this point and you're convinced that you're dealing with a syndrome and you talk to them and describe it, in most cases, I notice a paradigm shift. A light goes on. They say, oh, and that's when I know that they're going to get better because they've seen it. But unfortunately, it's not in every case. So I would say the minority, there are a few patients like the one I mentioned, they're just not going to buy it. You're missing something, doctor. You know, it's my prostate, it's my vagina. There's something there, you're missing it. But mostly, because they've been through the gamut of investigations, they get it. There's something else going on, and we can show them what it's going because it's not hocus pocus, it's science. How do we approach it? Well, Pain SA, which falls under the auspices of the International Association of the Study of Pain, an extraordinary organization, by the way. I've been to one of their conferences last year, and I'm going to one in next month. They are extraordinary people. They propose a biopsychosocial multimodal approach. Makes sense. The biological aspect, the psychological aspect, and the social need to be addressed with these people. Now, I send them home with quite a lot of literature, or I usually email it to afterwards. I don't have time to print it. But this is one of the things I'd like to just give them to I give to them, and I'll have to read it to you quickly because it makes sense to them anyway. Understanding acceptance. Your pain may have begun with an identifiable visible cause, infection, endometriosis, trauma, surgery, etc. You may have experienced trauma or abuse as a child, but now the pain is the disease. It results from abnormal signaling in the nervous system. There's no visible pathology to remove or treat. Learn about this complex syndrome. We will provide the references. Undertake a healthy lifestyle, etc. Avoid prolonged use of opioids and nonsteroidals, or you use the low doses possible. Undertake physical activity that your body will enjoy. That's very important because you change the signaling, the error signaling. Remember, I said the pelvis is a place of enjoyment. And if your pelvis is unhappy, but you can get physical enjoyment from Pilates or yoga or stretching or swimming or running or walking, those signals are positive and decrease the intensity of the pain. Sometimes the pain goes away during those periods and you get better because there's a positive reinforcement. Divert your attention to activities which allow you to forget the pain for a while, decreasing the signaling. Attend the support group. It does help, and it has helped. Have a realistic expectation about the road ahead. Your pain may not disappear completely, but you can expect it to recede significantly for much of the time, allowing you to have a good, fulfilling quality of life. You will find the way forward. We provide the key. You open the door. So the biopsychosocial approach, these words, medication, minimal surgical intervention. There's very little room for surgery, I'm afraid, all of our surgeons. Pelvic function physiotherapy, these are the biological approaches. Then there's psychological intervention. Most of these folks need a psychologist. Some of them have a psychiatrist, the support group. And I'll talk a little bit more about that. Alternative treatment. The only alternative treatment for which there is evidence is acupuncture. It does seem to help quite a few of them. And then, of course, a multidisciplinary or interdisciplinary team. I tend to work with the physios, and more than one, fortunately. Thank you, Karina, for spreading the word. Psychologists, OTs, pain specialists occasionally a sex therapist. Expect moderate improvement. Okay, we're talking about medication. Sorry. So medication doesn't provide a dramatic cure, for sure. It does help. You've got to be very careful. Choose the right medication. We used to think that Lyrica, pregabalin, was the go-to drug, but it now seems that the SNRIs are better, particularly duloxetine. Be careful of this drug. Got to get to know it's got some significant side effects. But I've been using it lately with some success. Acute options, non-steroidals, paracetamol is okay, and moderate opioids in judicious doses for short periods of time. very useful. Most of these people don't want opioid. They don't want to be addicted. They don't want pain medication. So it's really not a big deal. And then there are these other minimal invasive options, better installations. You're familiar with sacral nerve stimulation, not FDA approved for chronic pain, but it works in some cases. The challenge, we're nearing the end, by the way, of this presentation. The challenge is that we have an incorrect reimbursement model. Patients have to pay for each specialist they go to, the physios and the psychiatrists and the psychologists. And so it's been challenging. So they come to me or to folks who practice what we do, and they have this epiphanous turnaround. And then what? So they're now convinced that the way forward is this multimodal approach, etc. But how do they afford it? So what I've set up is, firstly, they can email me anytime. There's a follow-up at no charge. And then there's this open educational support group for which they pay 50 Rand just to cover my Prime Zoom fees. And I mean, admittedly, I'm at a stage in my career that I can afford the time and the energy to put into this with very little total reimbursement. So it's a problem. How do I replicate this model? The model works in the few patients that we see. I don't know, 3 or 4, 5 a month. How do we scale it up? One of the ways is consider if you're a part-time gynecologist, you have children at home, you want to work by this maybe if you have an interest. This is my email. I'm also happy to accept referrals, and all the referrals come from my specialist colleagues, the urologists and gynecologists, and many from patients who somehow get to know about it. Not usually from the GPs, but as I say, I'm happy to accept referrals, but send me the email, let me look at the situation and determine whether it's appropriate. Okay, so how do I go back? Hang on a sec. I just wanted to get you back there. All right. So, second last slide. Professor Romy Parker from UCT Pain Clinic has produced this extraordinary free book known as Understanding Pain. And I want to quote from that book as a last message. She describes a person-centered care, which involves adopting a treatment approach where the person with pain is an active participant in their treatment. And the goal of treatment goes beyond the eradication of the disease, rather to the optimization of life, restoring people to being able to engage in meaningful life roles. That is the goal. Quite simply, we aim to get people back to living. And that's from Prof. Romy Parker. So I hope that I have provided you folks with some improved understanding of pain, how it becomes chronic, the uniqueness of CPP, and the importance of its recognition. Thank you.
Steve, thank you very, very much indeed. It's been a wonderful presentation. Are you able to take some questions? I know that there are time constraints. Are you able to? We have got some online, yeah?
Absolutely. Got all the time in the world. The dogs aren't barking in Scarborough, so I think we'll be able to hear you.
The first question, Steve, from an anonymous person says, do you have any evidence-based data to prove that acupuncture is not bunkum? That's what they say. In other words, does acupuncture work, and is there a scientific basis for this modality of intervention?
The quick answer is yes.
Can you give it?
Well, I don't have it to hand, but and it's been a while since I read about it, but it's the only alternative medicine where they've actually done RCTs to prove that acupuncture does have a positive effect on pain. And I can dig up that literature if you can find the questioner's details. And
Yeah, that's anonymous. We don't know.
oh no, oh dear, oh dear. But yeah, I don't have it at hand. But I put it on the slide because it's I know about it.
Okay.
Mm.
Another one over here. Apart from acupuncture, do you know any other alternative methods of intervention that might be useful in pain, apart from acupuncture?
I really think that the hope the multimodal approach is how you have to do this. There isn't one particular bullet. If someone wants to propose on a question what helps, I mean, there's a lot of things that will help, and I'm happy to answer those questions. But um, the idea is to downregulate this upregulated central nervous system. You can buy any means. So if you feel good doing Pilates, massage, mindfulness, meditation, um, you know, the system's upregulated. These people are stressed and anxious, um, and the whole thing needs to calm down. So whatever you do to calm things down and decrease the error signaling will help.
Okay.
So yeah, so I mean, thanks, Steve. I think it's a very important conversation, a very important patient population. I do find though in my practice, there's often a very clear precipitous event, which is often difficult to unravel and disengage from. So we all know about the mesh issues. We know about endometriosis. We know about patients who might have had other pelvic surgery. And, they often get quite set on that specific event. You then go down a rabbit hole of trying to unravel that. And obviously, surgeons will often try and maybe, negate or, try and neutralize whatever was happening there. But yeah, I mean, it sounds like a lot of the patients that we were talking about are a little bit further down the line from that point of view. And I think often the difficult thing is to try and get them away from focusing on that problem. Lisa Kess and I are currently dealing with a patient who has had a few endometriosis surgeries. At the same time, during that whole event, they've done a BSO that removed her ovaries with an induction of some menopausal symptoms as well at the same time. So, although she's only about 40. So, these are often quite complex patients with some medical issues thrown into the mix. And, that's often the difficulty with these patients. I absolutely like your idea about, the emotional support. And often as doctors, we have to, spend time with these patients and talking them through the different things. That often helps a lot. But yeah, I mean, Pete, what is your sort of
Yeah,
feeling on this?
Steve, I want to know from you and Steve 1 and 2. Another modality which comes up is you mentioned the gate theory early on, Stephen.
Yeah.
And Stephen Jeffrey is a person that uses a lot of interstims, which is electrical stimulation. You've used it for OAB and other pain syndromes. How does it help both of you? I'd like to hear both of you's opinions. Interstim in this case, electrical gate theory interruption method to treat chronic pelvic pain. Steve Eppel first. Steve, are you familiar with the interstim?
Yeah, I was involved actually in Houston with some of the original work, and then yeah. So I've done I have in my past career done a lot of interstim. Theoretically, it sounds wonderful because you're augmenting the sensory input into S234 where the pain's occurring. And you're theoretically neuromodulating, they call it neuromodulation, you're neuromodulating that
We're still calling it.
reflex. Yeah. Um, and it should work. But I haven't found it to be dramatic with the patients that we're dealing with the nociplastic syndrome, mainly, where they've now well established. I mean, I think if you're at the end of your tether, it should definitely be tried. And you know, our Steve Jeffries is Prenderman Govender, the urologist who does a lot of InterStim, and so you know and has been successful. In fact, he may have a better answer. I don't know if he's doing more for pain, you know, than I was. Steve Jeffries, have you found a response with it?
Governor, we know him, yeah.
Yeah, so I did a lot of InterStim as well. And you know, the short answer is that it's not my go-to at all for pelvic pain. I've done about 2 or 3, and you know, from a physiological point of view, it makes sense why it doesn't really work, because unfortunately, you know, when you're doing it, you're aiming to get either S3 or S4 stimulation. These patients mostly have a more diverse cause of their pain. It's multimodal, it's multi neurological. We stimulate 1 or 2 nerves along the S3 or S4. But I've had a handful of patients who I've tried it, who I have used it in, but they've all invariably got some bladder symptoms at the same time. It's certainly not indicated or approved for chronic pelvic pain. But while we've said that all said, on Tuesday I did put in a sacral nerve stimulator in a patient who's got a lot of bladder symptoms, but a lot of bladder pain as well. But and some marginal success in 1 or 2 patients, but no, I mean it's really not a first line. And I think when you know in this chronic bowel, it doesn't really work that well. But I think if they've got a bladder source of a lot of these symptoms, absolutely. And I think even for interstitial cystitis, it doesn't work really that well. But if they've got a lot of urgency, frequency type symptoms in addition to the interstitial cystitis symptoms, it does work quite well.
Okay, thank you.
So yeah,
Steve, there's another question. We're running out of time here.
there are some questions here as well,
I'm
Pete.
trying to get them quickly while you're looking up your questions. What about Botox for a neuromodulator intervention for chronic pelvic pain? Steve, you've done that, a lot of that.
Which Steve?
Which Steve?
This Steve.
Okay, yeah, so have I.
Well, maybe Steve should answer that, but you know, we absolutely use Botox for patients with a lot of with bladder symptoms, urgency, frequency. But if I suspect that I will find some suggestion of interstitial cystitis at cystoscopy, including some microhemorrhages or something, then I will ortho Botox before, and I will do Botox in those patients as well. And it does work, and the EAU guidelines do support the use of Botox in patients with chronic pelvic pain and with some interstitial cystitis symptoms. But again, I think if it's more related to the urgency. Yeah, that's kind of my feeling on the whole thing. But I'd love to hear Steve's opinion on this as well.
Steve, do you have any experience with Botox under these circumstances?
I've never used it for pain specific unless unless there's demonstrable interstitial cystitis. Yeah, so if they've got Hunner's type small contracted bladders, I'll use it and it's quite good. But it's mainly to decrease their OAB, overactive bladder. But it is used in the pelvic floor for patients with severe pelvic floor spasm. One of my colleagues, Larry G, has used it with some success. But you know, I don't have any more experience than that.
Okay, thank you. We better start our
run through these questions quickly. Pete, is there any role for clonidine considering both its anxiolytic and pain modulation effects?
Yes or no, Steve Eppel?
No experience with it.
And you, Steve?
No, I don't really use it, but I think Milton Raff has he does use it as well.
Milton Raff, for those that don't know him, he's the local pain clinic chap. So he does use clonidine, so it's worth a try.
CBT in management of chronic pelvic pain.
What's CBT?
That's behavioral therapy. I mean, it's exactly what you're doing in your clinic as well, Steve, isn't it? I mean,
I don't know. I don't do CBT. It's a specialized psychological intervention shown to be really effective in chronic pain. Yes. So you've got to find a psychologist who knows what they're doing to do it and have room to do it. But yes, it is well recognized.
On that, sorry, I got confused between CBT and CBD. Anonymous says, is there any word on CBD oil, Steve Eppel? CBD is this oil.
No, there's no evidence that I know of particularly for chronic pelvic pain. No, that I know of.
Yeah, there's a lot of anecdotal evidence, not personally, but patients. Well, again, this patient I saw this morning, she said the only thing that really relieves the pain is pethidine and a spliff.
And a what?
A spliff.
What's a spliff?
Well, it's a it's a CBD or a cannabis
A Zol.
cigarette, or or Zol,
Zol.
or whatever you want to call it. There are multiple names for it, but you know, I mean, yeah, I've got a lot of anecdotal evidence of patients using it. I had a Odelung's wife, who's from a Karoo town, who started growing some cannabis in the garden,
And did it help her?
he was creating oil out of it, and she was quite sure about it working. But I mean, there's obviously, it's part of the whole placebo effect and relaxation. All these things are going to make some difference to these patients, and we need to support them in whatever way they are.
Whatever helps you.
Yeah, absolutely.
Absolutely.
Rindani's come up with a again, thank you for a comprehensive presentation. I have a few questions, okay? But the question that she's asking, what is your opinion about neuropelviology, which was started by Mark Possever, and his approaches to chronic pelvic pain, like laparoscopic neuronavigation techniques and neurostimulation, just to mention a few.
No, don't know about it.
Yeah,
Sorry.
so Steve, Mark Possever is a gynecologist who works out of Switzerland. They do extensive surgery. I mean, they're taking the completely opposite approach to you guys, Steve, and they go down and they do laparoscopic releases all the way down to sacrospinous fixation, sort of incisions and pudendal nerve releases. Very expensive treatment. I think I've got a patient in Cape Town who got a quote from those guys. It was something like 800,000 Rand to do the surgery. But look, but I mean, if you look at the evidence, they look at their treatments, etc. They, swear by it, and they are very busy. But I mean, this is a very captive audience as well for patients to have these neuro releases. And I mean, obviously, the more simple technique is, and the more robust technique is what you're suggesting. Yeah, but this is just about the laparoscopic nerve releases that we're seeing becoming very popular in Europe, and also guys like Nicela Lemos in Brazil and those places doing that surgery. But it's a very important discussion.
Steve, I've just got another question for you both. Which medication, Steve Eppel, seems to be most useful in the relief of chronic pelvic pain? If you had to choose one, which would you go for first?
Duloxetine.
Duloxetine. Okay, thank you very much.
SNRI, yes.
Glad you asked it,
now from the pain specialists from Pain SA. Some of the psychiatrists who, in fact, the president of Pain SA is her recommendation, Michelle King, for nociplastic pain, Duloxetine. And in fact, a friend of mine is a psychiatrist in Australia recommends it. He uses it, and I've
used where? Australia.
Yeah,
Australia. Yeah. So Duloxetine, you've got to start low doses and carefully. Yeah.
And obviously, those of us who would have thought about using Lyrica should rather try some duloxetine instead. And at what dose do you normally start these patients? If you think it's okay that we go for some sort of empiric treatment, if we've done the appropriate workup, etc., is it something that we can all start, or should we rather get them seen?
Yeah, I mean, no, I think we can use it. There are you've got to know about the drug interactions. I keep having to look it up, and the possible risks. Start at 30 milligrams slowly. It's once a day, 30 milligrams for say 7 to 10 days. Increase to 60, and I've got a patient on 120.
Okay.
But and they do report success. Significant improvement.
Steve, one last question, if we can do it. There's a person over here that says you mentioned Professor Wolf from Johannesburg, and you showed two pictures, enigmatic pictures. The second one was two toddlers in a play pool. What is the significance of two children in a play pond?
Oh, I was hoping for that question.
Well, there it's come.
Good. Well, the one little toddler is Professor Wolf. Well, the one is Professor Wolf, and the other one is me.
Very cute.
Okay, Steve. On that note, we unfortunately
asked that question because I was also looking at that, and I was also wondering where it was going to come up. And,
well, there you go.
I think it's a great way to end, and to leave.
And Steve's going to thank you, Steve.
Ideas to just a beautiful background, and great that you both ending up in the same Will, and treating the same type of patients, which is a great end to the, the story. Well, not the end, but ongoing, treatment of these patients. Steve, you've really given us great food for thought. You've enlightened us extensively, and I think these are very difficult patients. I think you've shown us the value of, the patient and enigmatic and emphatic doctor, actually.
Emphatic.
Emphatic, that's the right word. Empathetic doctor, actually, which is actually another right word. Just communicating with these patients, supporting them, not giving them that sort of really bored or dreaded look when they bring up these issues. But I think walking these patients through these problems is actually probably the most important thing, and supporting them appropriately and really trying not to operate on them too soon, which is maybe the real risk, and making things worse by doing that. So we really appreciate your time. I think we certainly will be taking up on your offer of sending patients to you. You do consult at Chris Barnard.
You do, he does.
And and I'm sure we'll be making use of your
I'll
services.
send 5 to him next month because it's a big problem. We always have these problems on our hands. Steve, thanks once again. Very kind.
Yes.
Like to also thank Steve,
Pleasure, Pete.
Jeffrey for being with us, Chris for being doing the assisting on the technical side, and then Steve Eppel. A great big thank you, and we look forward to hearing you once again on these platforms. Looking ahead, we've got Professor Kruger, the male fertility specialist. I don't know if you know him. He's a male fertility. We've had questions. Can we have something on male infertility rather? And gladly, he's fortunately agreed to come and present very shortly. So a great big thank you to you, Stephen, to Chris, to other Stephen, and safe home. All the very best. I'm not sure that there will be a presentation next week because it's a long weekend, Steve.
Yeah, I think we'll skip that one.
So people have said, can they have a break? I said, yes. So it's 2 weeks' time, same place, safe home, all the best. And thank you, Steve Eppel.
And thanks to you as
Thank
well.
you very much, gentlemen. Appreciate it.
Okay, bye-bye.
Bye.